Okay, so as you said, I'm Katie Hawkins. I am the bureau chief over Allied Health Services, and under that includes ambulance services, as you're probably guessing. I do understand that the agenda item was the GEMT program. I'm going to be very transparent that as of right now, that is exactly where you remember it being last time. It's on the table, but with zero momentum. It's an extremely complex program with a lot more burden on you all to complete cost reports and whatnot. So our current focus is to try to maximize on the existing program where the burden really is on the department. And we send a letter, you guys send money back, we send the whole thing back plus additional. So today may not be exactly what you're wanting to hear. I'm going to be very honest, like we've said, but we're doing the payment right now for the existing IGT program, and we are in the process of expediting contracts for providers that want to still be able to be eligible for a payment this cycle. It's a priority so we can try and get additional revenue. We're very well aware that our reimbursement rates are disgustingly low. I believe 40% of Medicare, give or take. There was a rate study done by a vendor not too long ago that included ambulance services within that. And it definitely documented that our reimbursement rates are something that need resolution, but right now I can't resolve those, but what I can do is try to get more of our eligible providers enrolled in this program. So again, Katie Hawkins, we're going to be talking about IGT. I'm not the greatest at tech sometimes, so bear with me. This program, as it stands right now, is only available to the providers that are government, publicly funded, owned, etc. The biggest reason for that is how federal Medicaid laws are set up. The only way that we can take additional funds to get federal match is with it being public funds. That's why the private providers cannot participate in this program, because the funding source for them is not already some form of state or locally owned funds. So on top of being eligible, we have to have a contract between your entity and the department. The biggest reason there is we're transferring funds. So it's to try to make sure all of the requirements are outlined, and then we can accept the funds in relation to this program to then be able to reimburse. And the part that gets a little funky that we always try to emphasize to our providers, because we've had a few people reach out to us asking if they can be a part of the program. One thing we're noticing right now is some are not even enrolled in Medicaid in the first place. Highly likely you are transporting Medicaid members. So step one would be to make sure that you are enrolled. Step two, bill us. And then step three, contract. But the part that gets a little hard is even if you enrolled in Montana Medicaid and started billing, you are not going to be eligible for a payment until 2024. And most of that is due to that we need to use a full data set of claims. We want to ensure that you've been able to bill and all the timely filing requirements have passed. So right now for this payment cycle, we are looking at any of your transports that were paid by Montana Medicaid from state fiscal year 21, so July 1st, 2020 through June 30th, 21. The only codes that we look at are the Medicaid covered codes, so your basic transports, your BLS, ALS, mileage, etc. This is a quick and dirty of the previous calculation for the supplemental payment. We did do some minor changes to the way that we calculate the payment. Your supplemental end result is the same, but your public fund liability is less, pushing more of it onto the feds. So what we do is we take your total paid units by code, compare to the Medicare versus Medicaid allowed, and calculate out that difference. So for this provider, for example, they will have a supplemental payment of approximately $8,400. Circling back to what we had talked about with the government-owned program, it is completely imperative on where the funds are generated. The feds are pretty particular about how we obtain funds to get theirs back. So on that, we send out an invoice that includes an amount that we need back so we can get the federal dollars. This presentation is going to be focusing today on how we changed the calculation to decrease your obligation and increase the feds. And part of that is all surrounding around the federal medical assistant percentages, and what that is for each dollar of Medicaid, the state is responsible for a certain percentage and the feds are responsible for another. And it is different based on an individual's eligibility group. So our Medicaid expansion population, the federal government is responsible for 90% of the expenditures out there. So by using that percentage, that greatly decreases the funds that you are required to submit for this program. I think we did the calculation to show the difference, and it ended up, we have a pretty small enrollment, maybe 23 providers right now that are enrolled in the existing program. And for those providers, it shifted $70,000 from them to the feds. It's a pretty sizable over 23 providers. So this is just the core, just showing how we split it out under the old method. Same calculation as you saw earlier, where it's units, Medicare, Medicaid calculation, but those last two columns are showing how we split out that dollar into the different funding sources, whether it be the feds versus the obligation that you all have. But this one is based off we're only looking at Medicaid, which is a 65-35 split. So a lot more state or public fund requirement than with Medicaid expansion. So for this one provider, they would have, under the previous method, would be responsible for nearly $3,000 of their $8,000 payment. But we are now making sure that we can capitalize on the appropriate federal share of that. So this is the exact same provider we've been talking about, but this time we have split their utilization out between eligibility groups. So you have your transports for your Medicaid members and your transport for your expansion members. And we as the department do all that split. We do all this back end work before we even send out an invoice. So go through the same calculation. Your Medicaid is using the FMAP of about 65%. Your expansion is using 90%, so we're saying the feds need to pay a lot more. So instead of about $3,000 needed to fund the total supplemental payment, this provider needs to send about $2,000. As you can see, the larger your pool of money, it makes a pretty decent impact. Timelines. We're already kind of past some of them. Our providers that are currently under an executed contract should have already received a letter from Linnea that included an invoice. Key things there, please make sure that when you send back your check, you are also sending a signed invoice. We cannot process any payment without that signed invoice. It's a certification, an extra certification that the funds you sent us are all public funds. We continue to do that to prevent audit risks for you and for us. And again, we're here because we really want more people to participate. Yes?
The questions our attorney reviews into this contract asks is, what exactly are we supposed to be sending you financially? Is this the money we have collected from our transports that are Medicaid transports?
It's not that particular in a sense. The funding stream that you all have from mill levies or taxes, et cetera, it just needs to be based from there. How that was, if it's related to your transports, that's not necessarily relevant in the sense of this existing program of IGT. The entire bit is that it just has to be classified and funded from your public dollars, your government public dollars, and then you're good.
So looked at this now for over 6 years.
Yep.
California, Washington, Oregon, Idaho, Colorado.
Yep.
Their programs, you don't send anything.
Correct.
To the government.
Correct. They use a different method.
Using some totally different method. And
Correct.
when you look at the cash flow problems this is going to create for local government to send you money on an ongoing basis to wait for a year or two to get the
You don't wait a year or two. We send the money back within 2 weeks, 2 to 3 weeks.
Okay, I thought that I read there that we have that year that we're sending it in.
I'm following. No, so what is confusing about that timetable is it's still, we pay it annually. So we are using your claims data, so yes, you are not fully brought up for at that time period. So when you send us a check, we issue out the supplemental payment for that calculation within 2 to 3 weeks. And the part about that, and it's going to sound absolutely ridiculous, is you send us the money and we send it all back, including what you sent us and the federal match. You get it all back. We hold on to it to say, thank you, feds, look, everything's fine, and then send it back.
Okay, so we're looking at a 2 to 3 week period.
Roughly.
And in this process, once you get signed up, do you have something for a financial manager for the data points that we need and management needs from our end that we have to provide to the office?
This program is a lot more simplistic than the ones that you've been reading from those other states. We are not doing any cost settlement, and it's not based off cost. It is purely based off of your paid transports and the differential between the Medicare allowed and the Medicaid allowed. It is to bring your Medicaid transports up to what Medicare would have paid you. It is definitely not the same as those programs. The obligation that the provider, that you all will have, is executing the contract, billing Medicaid, your transports. We send a letter that includes the invoice, review the invoice to make sure what you're seeing from us. So those units and codes make sense for what you're seeing. And then you sign the invoice, send the check and the invoice back to us. We capitalize, grab the federal funds, and send it back. But yes, it is not the same as those other programs. Those are a lot more complex and a lot more burden on the providers. I do understand that it does result in more revenue. But what we're also seeing is there's a lot more than just a revenue issue. Again, our enrollment for this provider community into the already existing easy, less administrative burden is extremely low. Extremely low. So if we can get you all moving over here, ideal. That doesn't mean we're not going to talk later about the other method, but if we can get your revenue up to Medicare in the meantime of that, that is what we would hope for. So that's kind of where it goes, because this, as odd as it sounds, the entire burden, aside from signing the contract and sending the check, is all on the department. We go through, we do all the data analytics, we do the invoice for you all and try to make it as streamlined as possible. So we're seeing that providers aren't enrolled. We're seeing that we may have some providers that are, but probably aren't billing consistently. So in addition to our rates being low, if we're not even getting the bills in the first place, you're definitely going to be losing out on even more funds.
So for the billing companies that are out there, whether it's MedRec or whatever else, are you working with them to be able to have them do this directly?
No. No, we have to do it directly with the public entity itself. But the billing aspect, we're hoping that your billers that you all use to submit claims, they're submitting your claims and they're getting paid. And if they're getting denials for any reason, they are reaching out to the appropriate sources to figure out why and correct any of the potential billing mistakes. Unfortunately, a lot of the ambulance denials are going to be around the fact that it was denied for medical necessity. That is a challenge with Medicaid. We know you transport because they called and you need to transport. But we definitely do not pay for all the transports just because they occurred. That's a whole other project that is also being looked at, but not making a whole lot of momentum quite yet. But it is on our radar. We're working pretty closely with Terry to look at other ways to try and do what we can within our existing programs. We really do want to assist what you all do for the communities. So the timeline's kind of here. Anybody that's new, timing is of the essence. And the biggest reason of that is if we do not receive the IGT payment by the 30th of December, we cannot pay you for that year. So if we can get new contracts in and executed no later than around November, that is ideal. As soon as we have an executed contract, we will ship off the invoice to you all or whoever executes, and then you can go from there. Because we really, throwing things. We really need to have the money before that, so we can get everything moving along. But at this time of year, it's a top priority for Linnea when stuff comes in to get it out. For the process that you talked to, so as soon as we receive our check, our admin ensures that it gets deposited. Linnea takes that, she approves that the amount received was appropriate, that we received a signed invoice, and we send that straight down to our fiscal authorizing payment. From everything I'm seeing, my 3 weeks is a really long timeline. It's pretty quick after that, but definitely need the invoice. The few we've already received did not have the signed invoice. This is really tiny, so I apologize. We have all of 10 copies of what a sample invoice looks like over with Linnea, but it's also going to look a little different than you've possibly seen in the past. We're giving a lot more detail, so you can see the differences between Medicaid, Medicaid expansion. Your financial people, if they want, can try to back into some of the data and ask a little more question. It's just a lot more at your fingertips to help confirm that everything's there. But, so big, giant, tiny text here. This is the part that you really want to narrow in on after you've checked all the amount. That first line is the amount of money that we need to be able to send you all $9,000, for example, for this example provider. And that last bit is that certification that everything here is appropriate. All the funds are right, and that it was certified by somebody that is able to make that financial decision. And a lot of that language is already going to be in that contract. That it's the big part of the contract, like we've talked about, is we're entering into this, and we, from the way that you've said you're incorporated under Montana law and what we know and what you know, your funds are generated from public funds, taxes, mill levies, etc. So then the other thing you need to know when you reach out to us, if you're a new provider or you have other people you know that really could benefit from this program, is those questions over there on the, if you're looking at it, the left, I guess, is how you're incorporated under Montana law. Local government is under Title VII. There's really no other way to kind of go about that. It helps us help you if we know exactly how your funds are derived. We've heard from some people that it's mill levies or taxes. Also, some people have said transports, but it's how do you function? Where are you getting your money to even exist without your transport? And then who controls the funds? So we do know that some of you all can get allocated the funds from, say, the county, for example, and you have it, but the county is fully responsible for ensuring that you have those funds available. And then enrolled. I know it seems really silly, but we definitely have seen that several providers that really want to participate in this are not even enrolled. And given that timeline that we talked about earlier, that's an essential step to try to be able to get payment out a little later. And to try to expedite the process, if anybody is interested and does not have an executed contract, please send me an email as soon as possible. And if you include your NPI and all the answers to those questions, we can turn things around pretty quickly. I have copies of about 10 draft contracts over here. If you have anybody that wants to take it now to look at it and have people analyze it, that might expedite your process. There's fields on that draft contract that we need to try and ensure we can get it moving along fairly quickly for anybody that wants to participate. And just the contact information for myself and Linnea. Linnea is the best day-to-day contact if you're running into billing issues or any other general questions relating to ambulance policy for Montana Medicaid. I'm only your primary contact for the new contracts to try to expedite it, since Linnea also has several other programs that she manages that also like to call a lot dentists. So we want to make sure that the contracts are priority one when we get those in. And that really is all I have in a nutshell in relation to this existing program. So, I do understand that it is not GEMT, and I know that that has something that's been going around and it has been talked about. But if we're looking at it this way, we just really need to get people involved in something that's already existing. Really, we just send your money right back as soon as we can. And with the rate study, if somebody emails me, I can get you some contact information to have access to that for you to be able to potentially utilize to have conversations about Medicaid rates. You do have an upcoming legislative session. And this...
That's where I'd ask is being on the board for city fire chiefs. Pushing for this as long as we have.
Correct.
I appreciate this as first step. But who is carrying the ball to take us to true GEMT funding?
I will also be fully transparent in that we do have a new Medicaid director. He is not able to be here today, Mike Randall. He is more supportive of an IGT program than he ever will be of anything that involves the CPE side of things. So we're pushing here, and then that, I know that you guys have been working on it for years. I worked with Dan quite a bit talking about it and doing, even just getting it changed to the expansion, utilizing that expansion FMAP. I have heard from a few of the meetings that we've had with other providers. We've met with some of the private providers. I do believe that they've been working with a vendor for potential discussion of that at more of a legislative level as well. So I fully empathize with the fact that I am acutely aware that you guys have been talking about this program for quite some time. PCG has talked quite a bit about it. They've met with us. So I'm not going to diminish the fact that that work has been put into it, but it's not, I would say it's not further than where you last recall it being. I'm not a sugar coater, so.
Well, I appreciate knowing it, because we can't fix something if we don't know it.
Exactly.
I was under the impression that we were going to have some stable, true GEMT solutions.
It has been under the review, yes. And Terry and I are in fairly, it feels like almost constant anymore, communication, but this GEMT is not at the same level of priority as some of the other projects we have. Like, we're not at far with it, but we're also looking at treat in place. Because another problem with our Medicaid, as we alluded to earlier, is we deny your transports. We will not pay you for your transports that are deemed not medically necessary by our utilization vendor. Okay, people are on Medicaid because they don't have money. So we're denying that transport. And then you can bill the individuals that don't have money. So the likelihood that you're getting revenue from that, pretty much non-existent. So potentials to help with a little bit of that is the programs that we're exploring. I make zero promises on how that works out, but what I do recommend is reaching out to me, and I can get you all some information on that rate study, because it is very clear from the review, and we've done it without that, but it's very clear from the review that our payments for emergency transports is laughable. I don't have any other word to say that. So then you guys will have that power at your fingertips. That's a whole different body that I can make zero promises that anything comes of it. But that entire rate study, EMS aside, showed some provider groups are definitely negatively impacted by Medicaid rates, which is not surprising to anybody that supports a Medicaid population and reimbursement level.
So for our department, we're not transporting, so the treatment place will be some funds we could access, you know, if we're gonna push our hand and get refusals, that would be happening. Just with that care, that kind of stuff. And then in the future, you look at that community care medicine, readmission rates need to be transferred.
Correct.
To the hospitals. So we implement those programs in our community, so. Who is driving those legislative pieces.
Those legislative pieces
Yeah,
of
who do we need to be
mean.
mean to? Who do we need to be?
Some of those programs I do know are already actively under so Medicaid is complex. I'm not going to sugarcoat that. We have a certain amount of funds that we get appropriated from the legislative body every biennium. We have to try to do what we can within those dollars. And so then anytime we want to add a program or change reimbursement of some sort, we have to do an internal analysis and propose it to the peeps above us. So our proposal would be, the ones that you're talking about would be the joint work with Terry's group over at the Public Health EMS. I really wish I remembered the name, but to try to spearhead that. The community one's a little bit bigger than Treat and Place. Treat and Place is, gosh, when did we say we wanted to try to have an internal analysis?
I think we'd like to have the internal analysis done sometime late spring.
That's right.
After the legislative session, kind of concludes. That would give us an opportunity to explore the best pathway forward. And kind of go through the process of negotiating the funds.
And I would say, and I'm not, public health and Medicaid, I believe, probably have a little bit better relationship now. We've learned quite a bit about what you all encounter through our work with Terry. There have been many years where Medicaid kind of lived in its silos of we pay bills, okay, moving on. We're trying to shift a little bit away from that. I sit and I can pay the bills, if you will, but I do not know what you guys encounter on a daily basis. I'm not even going to pretend that I know what that is. So it's imperative that we hear from you, we hear your stories. If you want to push from a legislative perspective, that all I can ever say is that it would be your local legislator that you would talk to see what they want to do. More from if it's from a more of an association aspect, sometimes it's a little bit more powerful than individual, but it doesn't hurt anything. The challenge is if we get told to do it, sometimes the details we get told to do don't really correlate to practice. It's more advantageous to work as a partnership, and I realize I just said that when you were probably also told the same thing with GEMT. Acutely aware of that as well. Bigger program, but when we're talking Treat and Place, that is something that is more likely to occur with a partnership, as it's more of a service offering. It's got a billable code where you can attach and make the code allowable and work on criteria and reimbursement. Something along those lines is a lot, it's not a guarantee, but it's a lot easier to implement than an entire program.
So, if I'm remembering correctly, individual departments in other states do direct GEMT and actual to the Department of Health. Is Department of Health going to be the stopgap in Montana to keep us from that?
I'm not sure that, I would need to know those states, because the only way you can capitalize on federal dollars is through a Medicaid state plan. So I mean, you could look at other areas, but the other states that have the private providers in it, it looks like the other entities may be doing it, but the revenue comes in from a tax. You may hear people call it a fee, but the revenue from the private providers would come in from a healthcare tax assessed on all caveats there. The funds would go to the Department of Revenue. The Department of Revenue lets Medicaid know it's there, and then we can use the approved Medicaid state plan. So that's our agreement. That's the Medicaid agreement with the feds, where it's we're gonna use, this is how we run the program. So because of that, if you agree to this, please send us your money of that portion. So that's our contract with the feds. So yeah, the DPHHS would kind of be the only, from the sense that there is absolutely really no way to get Medicaid funds without working through the Medicaid state plan. It does, for sure, because it does come out of different, Medicaid gets complex in how it shows up. And it specifically ties to Title 53. Taxation, on the other hand, is under a different title, but it has to be emphasized that this tax is for the purpose of. If you ever want to read anything on that, or it's like in existence, Montana has a healthcare tax on inpatient hospital, outpatient hospital, and nursing homes. So if you ever get bored and kind of want to read how that works. It's a little different than what a GEMT would be, but similar in concept of taxation to providers. Funds are then utilized to issue out. Awesome. Like I say, Linnea has copies of that really tiny invoice and 10 draft contracts. And the sooner that I hear back from anybody that may be interested in participating, the better. So we can try and get the payments made to y'all as fast as possible. See if I can
So
see.
your PowerPoint's available to.
Yeah, absolutely. Most definitely. I am was slightly underprepared, so I did not complete it until about 3 minutes before we left. But yes, I am more than, and the sad part is you saw most of it. So I'm more than happy to email it. If you can. That phone number is probably easier to remember if you don't get the email written down. You can just call it and I can give me your email address. But however you want to get a hold of us, Terry also knows how to get a hold of me if you have his contact information. So I really do appreciate all your guys' time, and I promise if I get invited again, I won't keep doing the same presentation, and I'll try to come up with something a little different next time.
Is the signature on the existing, assuming you have the existing contract,
Mhm.
does that have to match the invoice? Or
Not necessarily. So we have contracts where the fire chief signs it, for example, or I'm not even gonna pretend I know, so I'm just gonna use that example, where the fire chief signs the contract.
Sure.
But your invoice and the check is coming from, say, the county or city treasurer.
Oh,
And we're kind of doing from the honor system in a sense that this person is certifying that the check we got is all in the up and up. That they control the funds, that it's all public funds, you didn't get anything from anywhere else. So that is the key. But I will be very honest, I can't read signatures 90% of the time, so that's where I mean the honor system of, we've executed a contract with you and good faith that everything's done there. I highly doubt somebody's gonna write from their own personal bank a check, maybe, but not likely. And one thing we're encouraging on our new contracts is if we can get email addresses, we can get letters out quicker. We all know right now with the way that employment shortages are, USPS at times is not as quick as we used to recall it being. So if we have a point of contact with an email, we can always send out your letter and invoice that way. And that's something we've added to the contract template to try and ensure that we have a set stream of communication. So you all have what you need and we can communicate and get you the information pretty rapidly. I think I know how to do this. I think I know how to. Yes, thank you guys. I really do appreciate your time.